This training video provides guidance to first responders in leaving behind naloxone at the scene of an overdose or other circumstances where there is a concern about drug use. You will hear from Stephanie, who is in long-term recovery and has had personal experiences with overdose. You will also hear from Tim, an experienced paramedic who discusses overcoming barriers to leaving behind naloxone, including unfounded beliefs it is ineffective, could encourage further drug use, make the scene unsafe, should only be done with accidental drug use, or that it requires too much time.
My mother passed away in 2009 from ovarian cancer and left behind a Wegmans bag full of opiates. And I just started numbing the pain of losing her. And before I knew it, everything switched over to heroin. And then I was injecting, and then I ended up homeless, and all the things that I never thought would happen began happening and spiraling. I know I was Narcaned 3 to 6 times, and another time I was Narcaned by EMTs, and I refused going to the hospital and just took off. I really just remember waking up and being surrounded by EMTs and telling me what happened. And of course, I wasn't quite sure. And I think that's very common for us when we're coming back from experiencing an overdose. We don't really understand what is happening. I just remember being fearful, and I didn't have custody of my kids at this time, and I was scared that if someone found out that I overdosed, I'd get in more trouble. So I didn't go to the hospital. I just took off. I lost my husband to an overdose. He didn't have Narcan readily available where he was, and it took the people 45 minutes to call because they were fearful too. And that was a huge loss. My husband and I were, both in active addiction together, and just such a toxic relationship because we couldn't get sober together. We were both homeless. I overdosed twice within the week I went to detox, and I had just gotten out of detox and inpatient maybe a month before that. So I overdosed twice within the week leading up to go back to detox, and I just knew I was going to die if I didn't get help. And I didn't feel like I had much to live for. I My kids were it, and I didn't have them. And I didn't know if there was even a possibility of getting them back. And I just wanted to be normal. So I went and I gave it another try. It was in October, and Halloween was coming up, and I was on the phone with my dad, and I was like, I just want to leave. I want to be with the kids for Halloween. So my plan was to leave against medical advice, and thank goodness for my dad. And he said, Stephanie, you're doing this so you can be there for every other Halloween. And that shifted something in me. And I've been able to be there for every other Halloween since. Oh, life is, it's amazing and awful and all the things, but I get to feel them and I get to live them. I have custody of both of my kids. I have my own home. My son's graduating. His last day of school is next week. Life is good. Life is really good. And I just have to pinch myself sometimes because I didn't think I would be here to see so much of this stuff. And it's just amazing. I'm so thankful. In my experience, I feel that first responders maybe don't know that we're scared in that moment, not mad. Like, it's there's a lot of misinformation, like, we're gonna be angry and violent when we're getting Narcan and coming to, and with all the people that I've Narcaned, I've never experienced someone being violent, more so scared and unaware, of what's happening. Uh, I think if the compassion was there and understanding that, we're sick and we need help, and no matter how many times you've Narcaned us, we're still worthy. We're still people and community members, and we matter.
Stephanie's addiction began following her mother's death from cancer when she began using her mother's pain medications. Stephanie's husband died of overdose because there was no naloxone available and bystanders hesitated to call for help, a common scenario that underscores the importance of distributing naloxone in the community. Stephanie explains that when people are coming to from overdose, they are often confused and fearful, but unlikely to be violent. Stephanie also describes her life in long-term recovery, including her close relationships with her kids.
I am a paramedic. I've been working in the Monroe County area for about 20 years now, both rural, suburban, super urban, or suburban and rural departments as well. I have administered naloxone many times in the field over the last. I mean, it's increased a lot over the last 5-10 years, but yes, many times. The stigma around opiate use, it's very easy for people to just write these patients off, these people who are addicted to opiates, as junkies in alleys shooting heroin. But it's not that. This is a drug that does not discriminate. We've seen it at every level that we practice at, in every community it's out there. In my career, I've been to overdoses for kids as young as 8 and people as old as 80. And it is for all variety of reasons. There have been high school athletes that blow out shoulders and get hooked on oxy and then, graduate towards the harder stuff. Or it's just that they were prescribed, a fentanyl patch for their arthritis pain, and then they forgot they had it on and they took something else and ended up overdosing. So when we paint this picture of these junkies and like they're less than, it affects the care that they receive from other providers, because the providers arrive on scene and they're already going into it thinking this person is just another number that we're gonna squirt some stuff up their nose and move on for the day, and lose some compassion there and lose some of the humanity that we have. But it also hurts the larger community, because we start writing off large portions of people and claiming that they're not worthy of our care. We have a medication that is shown to reverse the effects of opiate overdose, and it works and it's easy to use. Anybody can give it and it's safe. Naloxone is proven to save lives. It's probably the one medication we carry that saved more lives than any other on the planet. It is effective, it's safe, it's easy to deliver. Why wouldn't we get this in the community? The same way we've done with the proliferation of AEDs and CPR training, this needs to be out there. We recognize there's an issue. We found a solution to the issue, at least a temporary one. Let's get it out in the community and encourage people to use this. People are going to do drugs regardless. If they're addicted, they're addicted. Us providing a life-saving medication to stop them from future overdoses is not going to be the thing that says, oh, I get to keep doing drugs. Allowing for them to have this safety net until they find their bottom and start their path to recovery is key. And as long as we're doing this to protect our community, to spend the appropriate amount of time with a family or bystander who may be in the area of an overdose when talking about leaving behind naloxone, we have to factor in what their relation to the patient is, what the scene is like. You can do it in as little as 5 minutes. So it's not like it takes a lot of time. There are times where I've spent up to a half hour, though, just hanging out and talking and speaking with the family and trying to hear their side of the story and then offering up what resources are available to them. Leaving behind naloxone at any scene does not make a scene unsafe. I think it really comes down to how do we educate the people on that scene and allow for them to understand the reason for us leaving it behind. Over 20 years now, I think I've had to get hands-on with a patient who started fighting and actually fighting with us once. Uh, they're going to wake up. They're going to be confused. It will be, it may be very frantic in the beginning stages, but you have to look at it from the patient perspective. I was just unconscious, and now I've woken up, and there are strangers who look an awful lot like authority figures standing over me saying, "Hey, you just overdosed on drugs." That would be a confusing experience for anybody. I might get a little bit frustrated as well if I have all these people cornering me in and I'm in an unknown space. So I think it comes down to providing space to that patient to allow them to come to, give them a moment, and then explain to them what happened instead of accusing them of what happened to them. At the scene of an overdose, when I leave naloxone behind, I start with understanding who is there and their relation to this patient, and try and get some information about the family. You try to build a connection with these people so that they're able to understand that I'm not coming from a place of being accusatory. I'm not a cop. I'm not trying to get information about, how I can get them in trouble later. I want to understand who they are and how they care about this person. And then I explain how the medication works and some of the effects of opiates and why this medication is effective in stopping that. And you try to make it as simple as possible so that they understand, hey, I see something that may be an overdose. We'll take this little nozzle and we'll put it up their nose and give it a quick squirt and potentially save a life. And when we're doing that and we're spending the time with the people who are leaving the medication behind on, that's really the key factor here. This isn't something you could just throw on a table, say, hey, have a good day, we're out of here, on to the next call. It takes some time.
Tim is a paramedic with 20 years of experience. He is correct in saying there is no evidence that distributing naloxone will lead to more drug use. Indeed, addiction is a vicious cycle that is likely to continue whether or not naloxone is left behind. But leaving naloxone adds a critical element of safety. Tim explains the overdose scene tells us nothing about how a patient's addiction began. This is certainly true. For example, if we had treated Stephanie for overdose, we would not know that her addiction began following her mother's death, when Stephanie began using her cancer pain medications. Tim states that patients are typically confused and fearful after being administered naloxone, and that aggressive behavior is rare. Stephanie also made this point. Like the placement of AEDs in public spaces and the widespread distribution of epinephrine pens, leaving naloxone behind at the scene of opioid overdoses allows life-saving treatment to begin immediately the next time an overdose occurs and before first responders arrive on scene. It just makes good sense. Tim's point that naloxone is effective is backed up by research showing that distributing naloxone is the most effective strategy to lower overdose deaths in a community, and that direct distribution to community members is the most efficient way to accomplish this. Tim explains how he goes about leaving naloxone behind, which can be done in as little as 5 minutes. We did not show it in the interest of time, but Tim described a longer interaction with the elderly mother of an overdose patient who was upset at the scene, had been in the dark about her daughter's drug use and was naive to naloxone. On that occasion, he spent a half hour calming her mother, educating her about addiction, discussing treatment options, and explaining how to use naloxone. Tim concludes by saying that distributing naloxone is not simply a matter of setting naloxone on the table and walking away. To leave behind naloxone effectively, it takes anywhere from 5 to 30 minutes. Given evidence for the life-saving effects of distributing naloxone, this is time well spent.